Yes, ma'am, we can start the class.
Hello, everyone. Hello, everyone. I'm Dr. Nawal Mohammed, and today we are back again uh, on the platform Auricle, where we will cover the topic epistaxis. Before we move ahead, a small brief about our platform. So, we belong to Oracle, a platform where we make sure that we teach students for their practical exams and for their theory exams. We give them rapid revisions of all important questions, volatile fact check revision, and high yield topics of all those subjects. So it is beneficial for everyone who prepare for next exam and for academic exam as well. There are a few topics in this which we have covered already, like rhinitis and all. But today we'll focus more on the topic of epistaxis. Why do you have to choose Oracle? We have recorded classes, live classes, we have practical sessions, hard copy books, and exam modules on our platform, which you can use and benefit from. We have flexible learning pattern on our platform with expert introduction and instructions, and also with convenient revision for all the students. Live classes, just like this, we have live classes where you can join in, you can have a question answer session if any, you can clear your doubts in any, and it's done by experienced educators, and we make sure that we cover all the topics in live sessions. Express exam modules, this will be like revisions where we'll cover the entire syllabus in 20 hours. So this is beneficial before your exams. So you can prepare for your exam and then you can use this as a revision tool. Anyone who has any doubt can also benefit from this platform because we make sure that we do one-to-one doubt clearing sessions with our students in a safe learning environment. We also have hard copy note sets made by experts. If you're not a fan of using textbooks, you can use these hard copy note sets where you have question answer patterns and you will know how to write the exam and how to present the exam in the academics. We also have a question bank from beginner to expert level. You can customize the question bank for better exam readiness, right? It is useful for academic NEET PGs and FMGs. We also make sure that we train students for practical sessions. We have 4 subscription plans on your screen. You can choose any if interested. You can use the QR code flashing on your screen for discount on subscription. So let's start with today's topic. So the today's topic that we have is epistaxis. Epistaxis is actually bleeding from inside the nose. That is the definition of epistaxis. But it is very important to understand that epistaxis itself is not a disease. It is a sign. It is a symptom of some disease. And every doctor who encounters a patient with epistaxis should make sure that he finds the cause of bleeding, be it local or constitutional cause. So you have to find the cause of the bleeding and you have to treat the cause. You do not treat the disease, you do not treat the symptom, you have to treat the disease. And epistaxis is not a disease, it is a sign, or we can see a symptom. There are 2 types of epistaxis. One is anterior epistaxis and the other one is posterior epistaxis. So this is classification of epistaxis. If the examiner asks you what is the classification of epistaxis, you should know that there are 2 types of epistaxis, anterior and posterior epistaxis. Now, anterior epistaxis means when the blood flows out from front of the nose, okay, and the patient is sitting. That's anterior epistaxis. What does it mean by posterior epistaxis? Means that the blood flows back into the throat. So it's actually an anterior epistaxis, but the blood will flow back into the throat, and the patient might swallow the blood, and he might even vomit the blood, and the doctor might assume that he's having hematemesis. Usually that's the case. Doctors think that it is hematemesis, but usually it's the epistaxis that the patient have swallowed. So if you can see on your screens, I have mentioned the difference between two anterior and posterior epistaxis. Posterior epistaxis is very rare. Most common is the anterior epistaxis, where you see the nose is bleeding. Now, there's an area called Little's area, which will come in the next slide on. So, Little's area is the area which is responsible for anterior epistaxis, or anterior part of the lateral wall of the nose, we say. Okay, that's the site of anterior epistaxis. And the posterior epistaxis is usually from the posterior superior part of the nasal cavity. Posterior superior. It is back and superior. Posterior superior part of the nasal cavity. And it is very difficult to localize if it is a posterior epistaxis. Like I mentioned before, the doctors might think it is hematemesis, but actually it is posterior epistaxis. Now, posterior epistaxis is most commonly seen in patients who are age of 40 years. That is most commonly seen in 40 years and above age of patients. And it is usually spontaneous in nature. And anterior epistaxis, what you see is you see it in children. All right. So it is very important that everyone knows the difference between anterior and posterior epistaxis. So anterior epistaxis, commonly seen, most commonly in children, occurs from the little areas of the nose, and posterior epistaxis is less common, but most severe posterior superior part of the nasal cavity, usually seen in old age. Okay. Now, posterior epistaxis is usually due to hypertension and in patients who have history of arteriosclerosis. Okay. Hypertension, arteriosclerosis. And posterior epistaxis bleeding is more severe compared to anterior epistaxis. Now, if anterior epistaxis is bleeding, you can see blood coming out from the nose. You ask the patient to pinch the tip of the nose, it will stop. The bleeding will stop. Pinching on the tip of the nose because it has Little's area. Whereas posterior epistaxis will require hospitalization because the patient will suffer from hemorrhage, might suffer from hemorrhage, and then the patient might require a post-nasal pack. We'll come to that. What is post-nasal pack? All right. So this is anterior and posterior epistaxis. Before we go deep into the topic, everyone should understand what is anterior epistaxis and posterior epistaxis. If you don't know what is the difference between anterior and posterior epistaxis, you won't be able to treat the patient. All right. Now, coming to the next topic is the site of epistaxis. Now, you know the difference of anterior and posterior epistaxis. Now, you should know the site of epistaxis. So, epistaxis, as we said, can be in the Little's area. 90% of cases are in Little's area. Okay. The bleeding from the site. So, this Little's area, common. 90% cases seen in children. Okay. So this will be Little's area. That's why you pinch the tip of the nose. It has chances of stopping to bleed. Now, other site is either above the level of middle turbinate or below the level of middle turbinate. So this is middle turbinate. Either above or either below. Now, why is this? This is because all the arteries, the branches of internal carotid artery and ophthalmic artery usually come together at the middle turbinate. So that's why it's either the above level of middle turbinate or below level of middle turbinate. So when it is above the level of middle turbinate, bleeding from above the level of middle turbinate is often anterior and posterior ethmoidal vessels. When we'll understand the anatomy of nasal septum, we'll have a brief idea about it. We'll be going to talk on that topic soon. Now, below the level of middle turbinate is from the branches of sphenopalatine artery. So I'll just write it here. Below sphenopalatine. I'm talking about the artery. All right. So below is sphenopalatine artery, and above the level of middle turbinate is anterior and posterior ethmoidal arteries. Right. Ethmoidal arteries. Okay. And then we have bleeding from the posterior part of nasal cavity. Here, the blood will directly flow into the pharynx, posterior part of nasal cavity. Into pharynx. Diffuse means from the nasal septum and the nasal wall together. Okay. This is usually seen in systemic conditions like hypertension, arteriosclerosis, whatnot. So diffuse means both from septum and nasal wall. All right. So sites of epistaxis is important. Types of epistaxis is important. Coming to the anatomy. So blood supply of nasal septum, you have to understand. So first of all, lateral wall of the nasal cavity, we have a picture of that. So we'll cover that. So lateral wall of the nasal cavity is supplied by internal carotid system branches and external carotid system branches. So there are two branches that plays an important role. Internal carotid and external carotid. The main thing we'll talk about is internal carotid. Internal carotid artery gives off a branch known as ophthalmic artery. Okay. And this ophthalmic artery will divide into anterior ethmoidal artery and posterior ethmoidal arteries. Remember, anterior ethmoidal artery and posterior ethmoidal arteries are above the level of middle concave. So if you can see, this is middle concave. The turbinate. Now, if you can see, it is above the level of middle turbinate. All right. And then we have other branches as well from the external carotid artery. So internal carotid artery comes from above. External carotid artery comes from down. Okay. So external carotid artery will give off a branch called as greater palatine artery. This is the one. It can give a branch lesser palatine artery. I think we don't have it in this diagram, lesser palatine artery, but keep it in your mind. All right. And it will give branches to lateral nasal branches of facial arteries. So external carotid artery will also give a branch to facial artery. And it will give off a branch to maxillary artery. And that maxillary artery will form a sphenopalatine artery, which is here. This is sphenopalatine artery, right? This one. Sphenopalatine artery is a branch of maxillary artery. Okay, I'll write it down here. And then gives off sphenopalatine artery. Remember, two branches for the lateral wall of the nasal cavity. Internal carotid artery gives off its branches. External carotid artery will give off its branches. Internal carotid artery will give off ophthalmic artery, and ophthalmic artery will give two branches, anterior ethmoidal artery and posterior ethmoidal artery. Both of these are above the middle turbinate, so it might cause bleeding above the middle turbinate. Now, below the middle turbinate are the branches of external carotid artery, that is sphenopalatine artery, which is a branch of maxillary artery, and maxillary artery is a branch of external carotid artery. Also, external carotid artery gives off a branch called facial artery, and facial artery branches out in the nose, on the anterior part of the nose, if you can see here. I hope the blood supply is clear. You have to draw the diagram in the exam hall if epistaxis is asked. You cannot write the answer without drawing this diagram. The examiner must know that the examinee knows the anatomy of nose to understand epistaxis. So please make sure that you draw the diagrams before you approach for the management of epistaxis. Now coming to the supply of the nasal septum. If you can see here, we have a diagram again, and the blue color highlight that you can see, this is Little's area. Okay. So now, again, internal carotid artery, external carotid artery, right? External carotid artery has greater palatine artery, which is a branch of maxillary artery. So now they might ask you what forms the little area. So you should know what forms the middle area, little areas. So little area is formed by septal branch of superior labral artery. Please write it down if you're listening. Septal branch of superior labral artery. Okay. Anterior ethmoidal artery branch of ophthalmic artery and sphenopalatine artery branch of maxillary artery, greater palatine artery branch of maxillary artery. You should write in that form in the exam. I think I'll write it down here. Little's area. Sphenopalatine artery. Sorry for my handwriting. Greater palatine artery. Facial artery, septal branch. Or you can just write superior labral artery. All these, and oh, sorry, and anterior ethmoidal artery. So in the exam hall, they might even ask you Little's area for 2 marks. So if they ask you for 2 marks, make sure you draw the diagram and then you write off these branches so that you score completely 2 points. All right. Now, I hope this is clear. Remember, internal carotid artery and external carotid artery will give off branches to supply the lateral wall of the nose and the nasal septum. All right. Know which arteries are involved in Little's area. Main artery is sphenopalatine artery. Sphenopalatine artery is a branch of maxillary artery. Remember this too. Now, moving ahead, what are the causes of epistaxis? The causes of epistaxis is divided into three: local, general, idiopathic. Local, general, idiopathic. Idiopathic is not known. Don't misinterpret that this comes under idiopathic. Local is divided into two: nose and nasopharynx. All right. And general is this one. So under nose, we have trauma, accidents, fingernail trauma, intranasal surgery, fractures, uh, sometimes hard blow over the nose can cause bleeding. Infections, viral rhinitis, atrophic rhinitis, tuberculosis, septal perforation, all these things. Foreign bodies can be maggots or leeches. Now, these are living. Non-living can be, magnets, neglected foreign bodies. If it is a non-living foreign body, neglected, like, you just ignore, usually seen in children. They insert a foreign body and the parents aren't aware about it. So, foreign bodies. Neoplasms, like cancers, hemangiomas, papillomas, carcinomas, sarcomas, all these are neoplasms. Atmospheric changes, high altitudes. And deviated nasal septum. Nasopharynx will have adenitis, malignant tumors, angiofibromas, polyps. All these conditions can cause nasopharynx. So local causes are two, nose and nasopharynx. So in exam, you should write it like this. Write local, number one, and then nose, nasopharynx, and then jot down the points. All right. Idiopathic is not known. Do not confuse that these comes under idiopathic. No, idiopathic is not known. It is general causes, either CVS, kidney disease, drugs, infection, tumors of mediastinum. All right. So tumors of mediastinum, how do they cause nasal bleeding is with the concept of raised venous pressure in the nose. So these, they will start compressing the venuses and it can cause increased pressure in the nose. So that's how mediastinal compressions and tumors of mediastinum causes nose bleeding. Drugs usually are anticoagulant drugs used in patients who are having heart diseases or in salicylates like aspirins and all, or in Ray's syndrome, right? So you can write one example, salicylate, anticoagulant. So we have now known the causes of epistaxis. How do you manage it? In any case of epistaxis, the first thing is to know the cause. It is important to know the cause and to do the first aid. And then if it doesn't stop, take the patient to the hospital. So the mode of onset and spontaneous or fingernail trauma, you should ask the patient the history. What is the cause? Is it sudden? If it is sudden, why sudden? Did they put the finger in the nose? Is it a nail trauma and all? Duration and frequency of bleeding, how frequent it is, how long it is bleeding from, how much it is bleeding from, amount of blood loss because it can cause hemorrhage or shock, side of nose from where the bleeding is occurring, either from the right or the left, from up or down, middle turbinate, so that you know which artery might be bleeding, whether the bleeding is from anterior posterior part. So that's why I have mentioned that it's very important that you know the sites and the classification of epistaxis so that it makes the diagnosis much easier. Now, any known bleeding tendency in patient or family history, you should take a family history, a thorough family history of any hypertension, leukemia, mitral valve disease, so that you know the medications, anticoagulants, and all, cirrhosis or nephritis, because it can be some general causes, or any history of drug, analgesics, or anticoagulants and all. All right. So this is the first step for managing the patient with epistaxis. Things to know before starting the management is these. All right. Coming to the next thing. You have to give first aid to the patient because you have to stop hemorrhagic shock. If the bleeding is very severe, you have to first give patient the first aid. Most of the time, the bleeding will occur from the littles area, right? From the tip of the nose, where all the arteries comes, moisal arteries, palatine artery, greater palatine artery and all. And it can be controlled by pinching the nose with thumb and index finger, like this, this. Okay. What you do by pinching is that you compress the vessels of the littles area. Now, this other method called Sporter's method, where the patient is made to sit, leaning a little forward over a basin to spit any blood and breathe quietly from the mouth. Okay. And give them cold compressions over the nose. Now, what does this do is that this will cause the reflex of vasoconstriction. When you breathe in, when you give cold compressions, it will cause vasoconstriction. You can see in the image here. Now, if you can see here, this boy is having a nasal pack. Not a nasal pack, it is a labial pack. So what the doctors have done is that they have compressed this part of his so that it can cause vasoconstriction, maybe because he was bleeding a lot. Okay. So Little's areas compression or Trotter's method. Make the patient to sit, lean a little bit forward over a basin to spit any blood, ask him to breathe quietly from the mouth, and give him cold compressions so that you can induce vasoconstriction. Now, general measures in epistaxis. You have done the first aid. Now, after first aid, you should make sure that you're doing the general measures in epistaxis. What is that? You ask the patient to make sit up with the back rest and record any blood loss and take place through spitting or vomiting. Number one. Number two, you can give him mild sedation if required. If he's feeling uneasy, give him mild sedation. Number three, make sure you check his vitals. Pulse, BP, respiration should be continuously monitored because if it is a heavy bleeding, it might lead to hemorrhage, right? Hemorrhagic shock. Maintain hemodynamics. Blood transfusion may be required, but is very rare. Unless and until it is a road traffic accident and the patient is just bleeding out of his nose, that's the only case you do blood transfusion. But as such, anterior epistaxis does not cause heavy bleeding that can lead to blood transfusion. Okay, so make sure you maintain the patient's hemodynamics. And antibiotics can be given to prevent sinusitis. Now, sinusitis is prevented if the patient is kept on pack. If you do the nasal packing beyond 24 hours, like if you ask him to come after 2 days with the nasal pack, you have to put him on antibiotics and send him off home. Now, we'll talk about nasal packing in the further classes. I mean in the further slides. But make sure that you put the patient on antibiotics when you're sending him back home with nasal pack. Okay? Followed by intermittent oxygen. Some patients might require intermittent oxygen if you're giving them bilateral packs. If both the nails are bleeding, you'll have to put a bilateral pack. And what you do is that you put them on intermittent oxygen. All right. Step 7 is investigate the cause. Treat the patient for local or general cause. Remember, epistaxis is a sign and it is not a disease. So these are the general measures that you do. First comes is that you manage the patient with important things like mode of onset, duration and frequency, amount of blood loss, where is the bleeding coming from? Is it anterior, posterior epistaxis? Does he have any family history? Does he have any disease history? Does he have any cancer? Is he on any medications? Then ask him, then get the first aid done. Let him pinch the nose or use Trotter's method, and then make sure you provide general measures in epistaxis. Now, between this, there are certain methods that you can use that comes under the topic of cauterization. Now, cauterization is a useful method that you can stop bleeding in patients who are having anterior epistaxis. When you know where the bleeding is happening from, when you localize the bleeding point, located it, then you can use the method of cautery. The area is first anesthetized topically. You use an anesthesia and the bleeding point is found and you cauterize it with a head of silver nitrate or coagulated with electrocautery. All right. So you can either use silver nitrate or electrocautery. Just write it down now. Cauterization. Done in anterior epistaxis. Okay. Use silver nitrate or electrocautery. Don't forget to give him anesthesia. Under local anesthesia. Okay. Now we come to the anterior nasal. Now this is the deal. In cases of active anterior epistaxis, the bleeding is not stopping. You ask the patient to pinch his nose, it's not stopping. You give him a Trotter's method, not stopping. So what you do is that you clear the nose from any blood clots by suction. Okay. And then try to attempt to localize the bleeding site. If it is a minor bleed and the size is accessible, use a cautery. Okay. If the bleeding is profuse and the site of bleeding is difficult to localize, then you do an anterior pack. I repeat, if the patient is having active anterior epistaxis, pinching is not working, Trotter's method is not working, you know the site, you have localized it, but the bleeding is minor, use a cautery. Okay. But if the bleeding is profuse and you're not able to localize the site, then you do anterior packing. So for anterior packing, what you do is that you use a ribbon gauze and you soak it in paraffin. Okay. Soak it in paraffin. All right. And after you soak it in paraffin, 1 meter of gauze is required in each nasal cavity if it is bilateral. All right. If it is bilateral, you require 1 meter gauze. So how much gauze you need? 1 meter gauze. Now, first few centimeters of gauze when you start putting it are folded upon themselves. So if you're taking a gauze piece, you make sure you fold it upon themselves. All right. And then you insert along the floor. You insert it along the floor and the whole nasal cavity is packed tightly. You have to make sure you make it tight so that it induces vasoconstriction. And you layer the gauze from floor to the roof. So from floor to the roof, you layer it. So if you see it here, you fold it few of them over each other. Okay. And then you make sure you push it inside, and you cover the floor to the roof from before backwards. Now, packing can also be done in vertical layers if you want it from back to front, or you can do it from front to back, whatever you want. One or both cavities might be needed to pack if it is bilateral. Now, make sure that you remove the pack after 24 hours if bleeding has stopped. Sometimes the pack can be kept for 2 to 3 hours, 2 to 3 days. Now, when you keep the pack for 2 to 3 days, in that case, make sure you send the patient back home on antibiotics. Because if you don't do so, the patient might have toxic shock syndromes. Okay? Okay. Ribbon gauze soaked in paraffin, fold upon each layer. Pack horizontally or vertically. Okay. Remove within 24 hours if bleeding stops. 2 to 3 days, put patient on antibiotics. Complication, write it down here. If you don't send the patient with antibiotics, he has high chances of having toxic shock syndrome. You can either do it horizontally or vertically, any way you want. This is from floor to roof. This is from backwards to forwards. Okay. Now coming to the posterior nasal packing. Now we have understood this point that anterior nasal packing is done in patients who are having bleeding from the anterior part and it is difficult to localize the bleeding. Posterior nasal packing is done in posterior epistaxis. Now posterior epistaxis is difficult to manage, difficult to diagnose, usually above 40 years of age with history of hypertension. So it is required for patients with bleeding on posterior side of the nose and the blood is entering into their throat. Now, a post-nasal pack is first prepared by tying the three silk ties to a piece of gauze. So you take a piece of gauze like this, if you can see. All right. And what you do is by that gauze is that you tie three silk ties into a shape of cone. You put that gauze, you make that gauze in a shape of cone. And a rubber catheter is passed through the nose and it ends brought out from the mouth. Okay. So if you can see first here, a rubber catheter, you're sending it from the nose and you're bringing it out from the mouth. And end of the silk threads are tied to this rubber. Now what happens? You withdraw the pipe, the catheter from the nose. Now you put it inside and you bring it out from the mouth. And this end you tie it with the silk thread. And then you pull that catheter back out from the nose. So what does it happen? The gauze that you have tied to the other end is now in the posterior part of the nose. It's locking. Okay. And now anterior nasal cavity is packed. All right. So the ends of silk thread are tied to the catheter and the catheter is withdrawn from the nose. Now, the pack which follows the silk thread is guided into the nasopharynx. This is this one on the index finger. The third silk thread is cut short and allowed to hang in the nasopharynx. Now, you have to make sure that the third silk thread is hanging in the nasopharynx, if you can see it here. So this is one. Three silk threads they are talking about. So this is one, this is two, this is three. Okay. So the third silk thread is cut short and it is allowed to hang in the oropharynx. Now it helps in easy removal of the pack if you keep it like that. Three silk threads you have to tie. One is hanging, one is to this gauze, and one is to the catheter. Now you pull it out, you pull the catheter back, it is going to pack the posterior part of the nose. All right. So this is posterior packing. Patients who require posterior nasal pack should always be hospitalized. And instead of posterior nasal pack nowadays, we use a Foley catheter of size 12 to 14F. Okay. After inserting that catheter, just like that, we insert the catheter and we inflate the balloon. We don't inflate the balloon with air, but we inflate the balloon with 5 to 10 ml of saline. The bulb is inflated and the saline is kept there and it is pulled forward. Now, when it pulls forward in the concha, it is blocked. Okay. Now, this is anterior nasal pack. If you want to do a posterior nasal pack, you can inflate both the balloons. I think we have it here. Like you can see it here. 1, 2. Can be used for anterior and posterior nasal pack. Both. Or you can just use it for posterior nasal pack. Okay. See it here. We have done a procedure of posterior nasal pack. Attached the gauze piece to the end of the catheter. And we pull the catheter out and we use our finger to push the pack behind in the nasopharynx. And we make sure we keep the thread hanging. So these are the procedures. Apart from this, we have endoscopic procedures, endoscopic cauterization. So in endoscopic cauterization, What does it do is that it helps in better location of the posterior bleed. The bleeding point is localized with a rigid endoscope, okay, and then cauterized by using a cautery. This procedure is useful with less morbidity and it decreases the hospital stay, but it has limitation when profuse bleeding is happening, and it does not permit the localization of the bleeding. So you can use endoscopic cauterization as well, which is very successful. It helps in better localization of the posterior bleed. It is done under a local anesthesia, and the bleed is coagulated by using a cautery. Other than that, we have elevation of mucoperichondrial flap, or we say it as submucous resection (SMR), submucous resection (SMR). So here what we do is that we ligate off the vessels. Now, in case of recurrent bleeds from the septum, what we do is that we just elevate the mucoperichondrial flap and then we reposition it back when it is fibrosed. Because when it becomes fibrosed, it constricts the blood vessels. I repeat, what happens in mucoperichondrial flap is that, first of all, the indication is recurrent bleeding of the septum. So we just elevate the mucoperichondrial flap and we let it heal. When it becomes fibrosed, it constricts the blood vessels and this will stop bleeding. Now, submucous resection operation can be done to achieve the same result. Or what we do is that sometimes we just remove the spur if the spur is the cause of epistaxis. Apart from that, we also ligate the vessels. We can ligate external carotid artery if its branches are the cause of bleeding. When the bleeding is from the external carotid artery system, remember the branches of external carotid artery, right? And all the conservative managements have failed. What we do is that we ligate the external carotid artery. It is avoided now. The procedure is avoided now because it causes, complications, and we favor more of embolization of sphenopalatine artery itself, because sphenopalatine artery is the most common cause of epistaxis if it is from the external carotid artery. Okay. Now, we can also ligate maxillary artery. Now, ligation of this artery is done in uncontrolled posterior epistaxis. All right. If the cause is not known and it is not controlled, we use that procedure. So posterior wall of maxillary sinus, you remove it, and then the maxillary artery or its branches are blocked. This procedure is known as Caldwell-Luke operation. I'll write it down. Ethmoidal arteries. Ethmoidal arteries, remember, it is an anterior superior bleeding above the middle turbinate, right? And not controlled by parking, then you ligate it. Anterior and posterior ethmoidal arteries, which supplies the areas, can be ligated. Now, but this is very rare. These vessels are exposed in the medial wall of the orbit by an external ethmoidal incision. Just remember that we can ligate the arteries as well. So, coming to the point, remember the management. You first have to make sure you take a proper history. Management of epistaxis is important. You must know the management. First of all, make sure you take a history, proper history. Then give the patient first aid, all right, and do the general measures of epistaxis. Followed by, even after that, if the bleeding doesn't stop, you go for packing. It can be either anterior nasal pack or a posterior nasal pack, depending upon the type of epistaxis. Two types of epistaxis, anterior and posterior. So, if it is anterior epistaxis, you take a ribbon gauze, soak it in paraffin, fold upon each other, and then cover it from the floor to the roof. All right. And if you're deciding to keep the pack for 2 to 3 days, send the patient off with antibiotics. If not, the patient might land up into toxic shock syndrome. Coming to posterior nasal packing, you use a catheter, you insert it from the nose, bringing out from the mouth, tie a silk thread, which is tied to a gauze, pull the catheter out, use your finger to put the pack back in the nasopharynx. Okay. But now we have more advanced technique where we use a balloon, a nasal balloon. If you want to use an anterior pack, just open up one balloon. If you want to use both, you open up both the balloons. Okay, you can use an endoscopic cautery. We use a rigid endoscope. Put it in cautery, the bleeding vessel. If you're not able to do that, you have to ligate the blood vessels. Epistaxis definition. Remember, epistaxis is not a disease, but a sign within itself. I hope that's clear. Thanks for watching. Done. Thank you.
Thank you, ma'am.
Thank you.